Good morning, everyone. How are you all doing? Hopefully some people are in the stream. Let's see. Is anyone there to confirm they can hear me by any chance? Oh, fantastic. Hello, Sarah. Just gonna give it a few minutes before we get kicking off here. It's good morning. You guys getting a lot of buffering, or does it seem like the stream is okay? Because I'm getting an error here on my side, so I'm not sure if my internet is gonna do okay or not. We shall see, though. Hello, Hannah. Did have my windows open. Oh, that's good. That's good. Fantastic. Yeah, I did have my windows open this morning because it is quite cool outside. However, the sandhill cranes decided they wanted to have a party, so they were squawking pretty loud, so I had to close that off. But it is what it is. Good morning, Vivi. Anyone have any good quarantine stories or anything interesting going on besides being locked away? So just about another minute or two, and we'll go ahead and get started. All right, well, it's 10 o'clock, and I think some people will probably be filing in shortly. Any questions or anything we're covering so far? Just pop it up in the chat there. Let me open up the sticky notes here, just in case anyone wants to post a question there. Yeah, so I went ahead and I graded the second prescription assignment, so that's all complete. Um, so I'll get working on that third one. It should be done probably by today or tomorrow, if I had to guess. Um, for the most part, they were pretty good. I think the only issue I ran into pretty consistently is the antibiotic selection, which a lot of people were choosing to use like two beta lactams together for like double coverage of Pseudomonas. And so that was kind of the one thing I noticed. It was kind of like the big no-no. So you got to make sure that if you're double covering for Pseudomonas, you have to go with two different classifications of drugs. So if you wanted to go with like a fluoroquinolone plus carbapenem, for instance, or if you want to do like cefepime plus an aminoglycoside, that would have been appropriate. But like using cefepime plus piperacillin tazobactam is not appropriate, since they have basically the same mechanism. I also saw a lot of people using ceftazidime, which, if you recall, we don't like using for Pseudomonas coverage, at least for empiric coverage, mainly due to the fact that you do have a lot of resistance to that, or it does develop pretty quickly. So we kind of avoid doing that. So, but that's it. So if you have any other questions about the prescription assignments, certainly let me know. We can talk more about that. Let's see. I'm going to go ahead and start recording here. Let's see. So no questions or anything like that regarding anything we've covered so far. Hoping someone else will put something in the chat so I can make sure that I'm not just talking out to the void and you guys can actually still hear me. There's a bit of a delay there, though. Oh, fantastic. All right. I just feel like I'm just talking to myself, but that's okay. I'm pretty used to that. I did attend a webinar yesterday. It was pretty interesting. It was through the ACMT, which is the American College of Medical Toxicology. And so that's basically sort of like the physician counterpart to the group that I'm with, which is the American Board of Applied Toxicology. And so they're going to do this like weekly webinar, but it's pretty neat because they had a couple of speakers come in and talk about things like ACE inhibitors and ARBs and NSAIDs, like we talked about last time. And they actually had an infectious disease pharmacist come in and talk about remdesivir and seeing if that was going to be something that's like a potential therapy. Ultimately, they came down with is that we kind of don't know right now. There's a lot of speculation, but not a lot of clear clinical evidence. And so as of right now, it's kind of interesting because they're looking at whether things like anti-inflammatories like NSAIDs and corticosteroids might actually help or hurt these patients with COVID-19. And a lot of it came down to is like, well, there's a camp that thinks that having those on board may be really beneficial, and some of them think that it may harm the patient. So it's kind of like, well, we just don't know. And so, kind of like just carry on treating like you normally would. So if a patient's a good candidate for an NSAID, if they have osteoarthritis and they've been taking it for a while and they're not having any issues, well, there's no reason to stop necessarily. Or if they're on an ACE inhibitor, they have CHF or something, leave them on it. There's no reason to take them off as it currently stands. But the more interesting thing that came on, they actually had a couple of ER and ICU docs come in and talk about their experiences so far. There's one from Italy that was kind of talking about their experiences there. But the really interesting one was talking to an ER doc who was working in somewhere in Queens at a hospital there in the ER. And it was just really kind of tragic and really kind of interesting hearing his perspective on things, talking about the different changes in terms of their workflow that they had to change to accommodate all of these patients. He kind of talked about being the epicenter of the epicenter, essentially. And so they're talking about how normally they would have, in the ER, you have different areas, like your fast track area, your more critical care areas, and there's usually a set of beds called the resus beds or resuscitation beds, where you have someone like a cardiac arrest or something, they would go to those beds where the most sick patients go to. And they said normally they have like 7 resus beds available, and they had to convert that all over into basically 31 spots for patients to go on ventilators, because some of these patients are developing respiratory failure and requiring intubation. Talking about moving like the peds ER out of the building entirely just to make more room for these patients with coronavirus. And so pretty interesting there. And also, which is pertinent to what we're talking about today, we're going to talk a lot about intubation and rapid sequence intubation of patients. And this is a really big concern with patients with coronavirus because of the fact that droplet spreads via droplet transmission. And when intubating patients, you have to be really careful here because there is risk for things like aerosolization of respiratory tract particles from these patients while being intubated. They're talking about using different means of different techniques and things like that to try to minimize the infectious spread of the disease during this really kind of intensive process here. So anyway, that's kind of the segue getting into talking about our emergency medicine topic here. Another interesting thing they talked about was that, being in New York, they have pretty good pizza from what I hear, and they said that a lot of the healthcare providers talk about the COVID-19, which is the 19 pounds they all gained from the amount of free pizza that they're getting during their hospital shifts. So I thought that was pretty cute. So without further ado, let's get into our topic here. We're going to be covering some of our emergency medicine topics. You're going to get a lot more of this during the summertime when you get into your ACLS and your ACLS section, and then also when we talk about in your ER section for CMS. You'll probably see a lot of overlap there, but here's what I want to introduce the medications we're going to be talking about. So I don't know if any of you perhaps have maybe partaken in an RSI or been present towards one. You can kind of chime in and say kind of how your experiences might have compared to what we're talking about here. So I'll be talking about it from a drug sort of standpoint. And so when we're talking about RSI, it just means a rapid sequence intubation, which just refers to the idea that you're having a patient who is either not protecting their airway or they are not able to oxygenate appropriately enough, and we need to take over that act for them, meaning we need to get an endotracheal tube down into the patient such that we can then hook them up to either a bag valve or a bag, we can hook them up to a ventilator, and we can breathe for them essentially. And so frequently this happens in the ER, but this may happen out in the field via EMS. This may happen in the ICU. And certainly in surgery, you'll see that your anesthesia colleagues will be performing a lot of these. And so, if it can be done electively, that's nice because usually patients are they're not quite as sick when doing that. You have a little bit more time to kind of prepare the patient. But a lot of times in the ER setting, you really don't have that luxury. And so it's like, you got to get it done now. And so this is why it's a rapid process that we're going to get into. So as I mentioned, this is a rapid sequential process, and it's one of those things you'll see there's a lot of simulation around. There's a lot of practice that goes into this because it can be a pretty hectic situation, and they don't always go as planned. And so you always want to make sure that you have backup steps in process. You want to make sure that you have the right people there, the right techniques available, and all these different things to deal with these patients. And so where I come into play, where the pharmacist comes into play, is with the medication aspect, obviously. And so there are quite a few medications that go into this, and we'll talk about ones that are used here and ones that are appropriate or maybe inappropriate, depending on the type of patient you're dealing with. And I'll kind of bring up some clinical situations that I've run into to kind of illustrate these points here. So you'll see there's kind of 3 steps to this process here prior to actually doing the endotracheal intubation and actually doing the laryngoscopy. And so there's the preparation stage where you're getting medications on board potentially that patients may require based off of things like, are they an asthmatic patient, or did they come in with a traumatic brain injury? Like, what is the reason why they're being intubated, and are there certain medications that may need prior to actually getting the intubation done? The next point here is going to be you sedate the patient, because no one wants to be awake for this process. It is pretty traumatic if someone were to be conscious during this. And then we'll undergo paralysis. And so basically, by paralyzing the patient, and this will be kind of where we kind of slide in most of our paralytics we're going to talk about, you allow for loosening up all of the airway muscles to allow for the patient to become more compliant, such that when you're using your laryngoscope, you can go ahead and open up the airway such that you can go ahead and get that tube down into the lungs so you can start to breathe for the patient there. So this is the sequential process because, as you might imagine, you probably don't want to paralyze a patient prior to sedating them. That would be, again, quite traumatic for your patient. So you don't really want to do that. And again, the whole point here is to facilitate really safe and emergent tracheal intubation, something where you may not have a whole lot of time in order to kind of get this kicked off. So history is really important. If you can get this prior to a patient being intubated here, you want to figure out, like, do they have allergies to certain medications that may preclude them from getting one thing or another? Do they have any history of things like neuromuscular disease? We're going to get into a topic called malignant hyperthermia today. That is something you want to be really cautious with. And we've talked about that previously, actually. Does anyone remember what drugs we talked about causing malignant hyperthermia? You can put it in the chat there, and I'll kind of refer back to that. But with this neuromuscular disease, small kids might be undiagnosed, so this can be a difficult thing to ascertain. So we'd like to ask about, is there family history of issues? Do you have family history of people maybe having bad reactions to anesthesia or to being intubated? We can look at things like renal compromise. We can look at things like, do they have asthma? Yes, very good, halogens. And Courtney said that correctly, as well as Melanie. Yeah, so basically any of the inhaled anesthetics we talked about, other than like nitrous oxide, those can certainly cause malignant hyperthermia. And then, do they have previous intubations or experience with anesthesia? Do they have bad reactions to a particular drug or something? You want to be able to kind of get that in terms of the history. Can you always get all of this information? Not necessarily, especially if they come in. We would see this quite frequently from a tox perspective, where patients had maybe been subject to an opioid overdose, or maybe a combination of like benzos and opioids and alcohol, for instance, and their mental status is such that that's why we're intubating them, because they're not protecting the airway. They obviously can't provide a history for us. So again, it's not always an ideal situation. So, looking at the pretreatment, we're kind of expect to see certain physiologic responses as a result of laryngoscopy. So certain physiologic things happen as a result of this. So for instance, you can see variable changes in heart rate. Typically, one of the things you may see initially is a little bit of a bump in heart rate, but then patients tend to have kind of a vagal response to this. And so you can definitely see depression in the heart rate. You can see bradycardia as a result of this, which may not be great if one of your patients already bradycardic, or if some of the medications we're going to be giving them a little bit later, as we'll see, can also have a decrease in heart rate. So this will be an important concept for pre-treatment, something we can give to help manage that. We also want to consider that other things that will have increases include things like intracranial pressure. You can see increases in blood pressure, and you can see some increase in airway resistance, especially people who are a little more sensitive. You may get things like bronchospasm occurring here. So these are things we can try to pre-treat for and try to help to mitigate these expected physiologic changes to basically facilitate a very safe and easy way to intubate these patients, hopefully. So the first medication we're going to give here, and I just kind of give an example of the Bristajet or the Abiject you're going to see out there. If you ever get out there in the clinical world, if it's COVID-19, everything ever blows over, here's an example of if you go to look at a code card or something like that, you're going to see certain medications here. And oftentimes they come in these boxes, and we'll talk about these a little bit later in terms of how these operate. But basically, these are pre-filled syringes that you can administer to patients. They're pre-filled, so that way you can facilitate giving them pretty rapidly. You don't have to memorize the doses specifically here. These are just kind of for reference. But the reason why I include these points here, or the big things to take away, is like when you would want to give these drugs. And if we're giving them, like, who do you want to be cautious with and giving them, what kind of contraindications are there? If I give you a clinical scenario, be able to know which pre-treatment drugs these patients should require or which ones they should receive. Those are good things to know there. So anyway, so when looking at this, we like to give lidocaine mainly because this actually helps to blunt this rise in ICP, or this intracranial pressure in patients, especially with traumatic brain injury, or for whatever reason they're having cerebral edema, or whatever reason their intracranial pressure is a concern. This is something that we can administer to that. Even if they have a suspicion of an increased intracranial pressure, we can go ahead and administer this. The idea is by giving lidocaine, being a local anesthetic, it's designed to help kind of blunt the gag reflex a little bit. So when we're undergoing laryngoscopy, we'll get some activation of that gag reflex, which should be mitigated to some degree with our sedative drugs, but this can help that as well. And as you might imagine, if you were to gag, you might imagine that pressure in the head is going to go up, and so this helps to blunt that to some degree. And of course, you want to be cautious. And again, usually with just a single dose like this, we're not really worried about patients with like organ dysfunction because it's just a one-time dose and they can clear it pretty well. Can anyone remember when we'd give like lidocaine maybe as like a continuous infusion? You can put that in the chat too, just to try to recall when else we might use that. But this is the main thing we'd end up using. If you had a patient with a history of like, head injury, say they were in a car wreck, they hit their head against the steering wheel, this would be definitely a medication you want to consider giving to that type of patient. So, again, I kind of gave away the answer already, so hopefully someone will put that in the chat before it shows up on the stream. But basically, we can use it also as an antiarrhythmic, and we'll talk about that when we get into the ACLS drugs a little bit later on. But again, this is going to blunt that transient increase in ICP during the actual laryngoscopy process there. So again, pretty beneficial, especially if you have anyone with an increased ICP risk that you're worried about. Okay. So then the next drug you might consider giving to patients who are getting intubated includes atropine. And so basically this drug is going to be utilized as an anti-muscarinic. And so the idea is it's going to have competitive antagonism on the muscarinic receptors on the heart. And so that should help to increase heart rate. So you'd expect to see increases in heart rate as a result of atropine utilization. That's probably the most common physiologic effect you're going to see is tachycardia. And so we would give this to patients either who maybe are coming in and they are already bradycardic, or if we're worried about them becoming bradycardic during the intubation process. So because we know that patients typically have a vagal response as a result of intubation, we can go ahead and give this if we are concerned that they're going to become bradycardic. So again, pretreatment, trying to treat a problem before it actually presents itself. So other reasons why patients may become bradycardic during intubation, not only just with direct visualization during laryngoscopy, but other things like hypoxia can do this. And then we're going to talk about succinylcholine, which I kind of lovingly abbreviate to SUX. We're going to talk about that a little bit later on. But succinylcholine, which is a paralytic that is commonly given during intubation, can also cause bradycardia, especially with repeated doses. So this is something we may give in order to prevent that. Especially for little kids too, they tend to be a little bit more sensitive to that effect from succinylcholine. So we frequently will pre-treat small children with atropine in order to help prevent that from occurring. So those are the main pre-treatment drugs you're going to see being used potentially. Again, not every patient is going to require that, but you do want to know which patients should get them based on, say, a clinical scenario that pops up, like on a test question or something like that. Okay. Next up are going to be our induction agents. These are going to be the drugs that we're using to sedate the patient in order to get them prepared for intubation here. And so some of these we've covered already, but we're going to talk about them in terms of how they're going to be used for intubation specifically, right? So because we talked about sedatives a lot during the surgery section last time, but we'll talk about them in this case here specifically with intubation, say like in the emergency department. So first up, we have Etomidate. So I'm sure most of you remember covering this previously. Now, some of the characteristics that you would like to have for like an ideal sedative agent when you're intubating is typically something you want to have working that works very quickly. So it has a fast onset and it has a pretty rapid offset. You don't want long-acting medications when you're intubating the patient. The reason for that is because, say for instance, someone has a seizure, right? So say they're coming in with a seizure and you're trying to manage that, but they're not really protecting their airway. You're worried about them maybe vomiting, or you're worried about them not breathing on their own. So you go ahead and decide to intubate. Well, frequently you don't want them to be on a long-term sedative right after that, because what if you want to go back in and do another neurologic exam? That's going to be impeded if a patient is sedate from the medications that you give. Or let's say you wanted to do someone with like a stroke, for instance, that you intubated, you don't want that sedative on board because you want to be able to again do that neuro exam for them potentially. So most often we like to have quick acting agents that should wear off relatively quickly. Now, if you recall back with that second prescription assignment we did, we were using we were using continuous infusions of things like fentanyl and midazolam in order to sedate patients while they are intubated. So again, this may be something where you will give one of these short-acting agents, get the patient intubated, and then you switch them over to, say, like a fentanyl Versed drip, or maybe put them on a Propofol drip or something like that in order to keep them sedated. But a lot of it is dependent on what do you need to do, right? Do you need to get this patient over to CT? Do you need to be able to do a good neurologic exam on these patients? It just really depends on the situation, right? Which we can talk more about later. So anyway, so getting into etomidate being our first sedative agent, this is probably far and away the most common one that I see being used in the emergency department standpoint, and the reason for that is multiple, as we'll see here in just a moment. It's kind of a pretty ideal agent. The biggest thing you're going to find is that it has pretty minimal hemodynamic effects here, which is nice, right? So we saw that, increases in blood pressure occur during laryngoscopy. You're going to have decreases in heart rate. You really don't want to have a lot of other medications that could be affecting that. So we like things like etomidate because it's pretty neutral. You shouldn't really see many changes in heart rate or blood pressure as a result of that. And you're going to see that it also does not have as big of a hit on the respiratory drive as you will see with other agents. And that's always the big concern, is by giving these big doses of sedatives, frequently patients will become apneic, which again, maybe that's the reason why they're getting intubated in the first place. But it may be something where you want them to be able to retain some of that respiratory drive on their own. So we'll talk about some different agents that can help out with that. But this will have pretty minimal effects overall as compared to some of the other ones that we're going to be or that we're going to be using here in just a moment. And again, basically, it's a different mechanism than a lot of other sedative agents we've seen. It does help to enhance GABA effects, which is why it's a sedative, but it's a kind of different classification than some of the other drugs we've seen, like benzos or barbiturates and things like that. So again, it's going to be enhancing GABA, working at that GABA A receptor complex. So basically the same site that things like your benzos and barbiturates work at, but just kind of a different part on the receptor that it works there. And so it can, depending on the dose that you're administering, can go anywhere from a light sleep all the way to deep coma where the patient is just absolutely obtunded, not protecting the airway whatsoever. And it's all dose dependent. So typically we're going to be giving these patients enough of a dose to where they're going to be unconscious, because we don't want them to really be aware during that intubation process, right, for the most part. And again, in terms of like the sedative effects, it can be quite strong, just like we see with like barbiturates in terms of like effects you might see on the EEG. But the benefit of etomidate, it's relatively short acting, which is why we like it. So most often you're going to see this used as an induction agent. You will sometimes see this being used for like procedural sedation. So we talked about that previously, where if maybe you have an adult patient who you're doing a quick procedure on, say for instance you're like reducing a dislocated joint or a fracture or something like that, you may see etomidate being used for those purposes as well. Because again, it doesn't have a big hit on the respiratory drive. You're less likely to see patients go apneic, which is why they might use it for that particular indication. If patients go apneic here, it's not as big of a deal because the idea is we're going to be breathing for them in just a few moments, right? And there's no big contraindications to its use, so we like it from that standpoint as well. In terms of onset, it has very rapid onset, so within a minute or two of this being pushed intravenously, patients will be unconscious. Basically, from the time it takes to get from the arm to the brain, which is fairly quick, so about a minute or two, and then it'll rapidly distribute to the CNS, but then it has really rapid clearance from the CNS as well. So it's a fast onset, fast offset, meaning that it's not going to stick around for very long. And so most of the time that's a good thing, but you may find potentially that maybe intubations don't go as planned. Maybe you need to give a second dose in order to get that patient resedated in order to facilitate that proper intubation. So we'll talk about that a little bit later on, what to do when maybe your drugs are starting to wear off potentially. So again, don't memorize the dose. I just kind of put it up there for reference here. And you're looking at the duration of sedation. It should be about 5 to 10 minutes or so. Hopefully by then your patient's intubated, but just be aware of the fact that it is relatively short acting there. Again, from an elimination standpoint, this isn't as big of a deal because you're going to be giving just a one-time dose. So we're not really so concerned about the clearance of it, because you shouldn't have much buildup, because they're going to get maybe 1, maybe 2 doses. Not really as big of a concern in terms of like stuff you might be giving as like a continuous infusion or something, right? But other things you're going to find is that if you use it with other sedatives, you're going to have increased effect. Most sedatives, when put together, especially with different mechanisms, are going to have synergy there. So that's something to watch out for, especially with opioids. You can definitely see that as well. And fortunately, there's no interactions with any neuromuscular blockers, which these are our paralytics, and that will be important because, as we saw in terms of RSI, there's the pretreatment, the sedation or the induction phase, and then there's the paralytic phase. And so we don't want really a lot of sedatives that are going to interact negatively with our neuromuscular blockers, and we'll talk about that in just a little bit. So in terms of side effects, some things you can see with Etomidate that are unique to it include things like trismus, and you can see some myoclonic jerking and muscle twitching associated with that, which for the most part is not clinically a concern, mainly because you're going to be paralyzing those patients anyway to help paralyze those muscles. We'll talk about that mechanism just a little bit, but there have been cases where patients' jaws will lock up, and as you might imagine, if you're trying to intubate the patient, that makes it quite difficult. Again, it can be overcome by paralytics, but that's a concern for some people. So some people have had bad experiences with Etomidate, don't really like it very much, but for the most part, this is the most widely used induction agent I see for intubations, whether it's kid or adults, really anyone. So this is another kind of unique side effect to Etomidate that's really important, especially for patients who may be going up to the ICU potentially, because where most of these patients will end up if they're being intubated. Melanie was asking, is the trismus from the intubation or from the Etomidate? Specifically from the Etomidate, due to those myoclonic interactions that Etomidate causes in those patients. So that's specifically what you're going to see there. But the important thing is, imagine you have someone who is, say for instance, septic, right? So they're coming in to the ER, they may be coming from the nursing home, they probably had a UTI that's now spread to the bloodstream, and so now they're septic, they're hypotensive. Cortisol is really important for those patients because we know it's a stress hormone. We know that it helps out in order to maintain blood pressure from its mineralocorticoid effects. And if you lose that, if you have decreased cortisol concentrations from the Etomidate, that can make it more difficult to manage their blood pressure. It can make it more difficult to manage their blood sugar. And so this is something patients or providers need to know about in order to overcome that, because we might give supplemental doses of hydrocortisone in order to account for that, up to, the 8 hours or so after the Etomidate is given. So one thing to consider, if you have someone up in the ICU and you can't really get their blood pressure under control and you're like, what's going on here? It could be related to this decrease in cortisol from the Etomidate. So that's one thing you want to look into from the ER records potentially. For the ER people, they don't really care because they're up in the ICU, so no big deal, right? Just kidding. It's always important to have good continuity of care. So up next are other induction agents we can use include our benzodiazepines. Most frequently you'll see midazolam or lorazepam being used here. These are good because they do provide sedation, they provide amnestic sort of properties there. We talked about that previously, and anticonvulsant properties. This might be good for someone who is maybe in status epilepticus who's being intubated from that standpoint, right? Typically Versed is a little bit faster onset but has a shorter duration than lorazepam, whereas lorazepam, on the other hand, is typically preferred, especially for seizures, because it does have a longer duration of action. Maybe a little bit slower onset, but it sticks around for longer in the CNS from that standpoint. Now, just to give an example of how much we're going to be giving here, and I think some of us kind of saw that during that second prescription assignment, kind of typical doses for things like Versed, for instance, with like continuous infusions. Most of the time these are going to be single doses that we're going to be giving here. Now I will tell you, a lot of people don't like benzos in use for intubations as an induction agent, mainly because of the fact that you don't get as deep of a sedation as you would see with something like Etomidate or maybe Propofol, and it does last a lot longer than you're going to see for some of these other agents. You'll have some patients that are still sedate from a single dose of Versed, even up to an hour potentially after they got that single dose. The main effects are about 15-20 minutes, but you can see lingering effects afterwards. So I've seen a couple providers that prefer this, but for the most part, this may be a good backup agent if maybe Etomidate is not available or they couldn't receive it for whatever reason there. But you will find that a lot of patients will maybe get intubated. They'll be induced with Etomidate, and then afterwards, once they're intubated, you'll find that the continuous infusion to keep them sedate while they're intubated may be something like a Versed plus a fentanyl, as most of you probably saw for that prescription assignment. So anyway, so some things you're going to see here, typically, especially when they're getting a continuous infusion like that, they can have buildup. And so people who you want to consider as might be having longer half-lives include those that are maybe obese, because, again, they have more adipose tissue for the drug to sort of accumulate in over the long term, or maybe they have CHF and they're having hepatic congestion and they can't really present the drug to the liver to metabolize it. Renal insufficiency. These are all things to where, say for instance, you had them on the Versed drip for say like a week or something like that, right? And again, that's another thing that a lot of those physicians up in New York were talking about being an issue in terms of once these patients are intubated, it's really difficult to get them off, those with coronavirus. But say they're on it for long term, say they're on the vent for a week or so, and you try to take them off, so you cut off the Versed drip, and you'd expect it to maybe wear off in 15-20 minutes, but they're still sedate for hours, maybe a day or two, right? Because they've had this buildup over time. And these are things you want to consider when evaluating these patients is, are they having buildup of the drug? And you can't just check a Versed level. So oftentimes you're going to be basing off of doing things like sedation holidays, right? So maybe you'll withdraw sedation from a patient, see how they respond. If they wake up very quickly, they start to agitate and start to move around, then you know that you don't have that buildup, versus they still are staying, basically stone cold sedated, then maybe it's due to that buildup of the drug they have there. So that's something you'll see in the ICU for kind of long-term intubated patients. They'll do what they call sedation holidays to see how they respond when they're cut off the sedation meds. So up next, we have ketamine, or Special K. This is, again, one of my favorite medications to administer to patients, mainly because it helps to provide good sedation, but from a dissociative sort of standpoint. So again, I kind of liken it to an out-of-body experience that patients will have. And interestingly enough, is derived from PCP or phencyclidine, which the street name for that was angel dust, which is something you don't really see a lot nowadays, but it has very similar actions, mainly because it's working via a totally different mechanism than a lot of what your other drugs are. So for instance, things like Etomidate and Versed are all working through the GABA A receptor here. This is a glutamate antagonist. So instead of enhancing the brakes on the system, we're actually taking our foot off the gas when we're doing this by helping to block the activity of glutamate. So anyway, so the reason why we like this is, one, it has a very short duration of action and pretty rapid acting. And again, we like to use this in kids a lot because of the fact that they typically have less likely to have some negative side effects, which we'll talk about in a moment here. And also the fact that it has these beneficial effects of not really affecting the respiratory drive very significantly. Not only that, but if you think about patients with like asthma, it helps with the bronchodilator effect as well. The reason for that is because it helps enhance catecholamine release, meaning you're going to have more norepi being released from this sympathetic nervous system. That means that you are going to see increases in heart rate, you're going to see increases in blood pressure, but you also see dilation of the bronchial smooth muscle, right? It means you're also going to have stimulation of breathing, meaning your patients are also going to stay breathing this whole time, right? If you give someone a big enough dose of IV Versed, they're going to stop breathing. If you give them a big enough dose of Etomidate, they're going to stop breathing. With ketamine, it's less likely to see that, which is why we like it from a procedural sedation standpoint. But also makes it really good for something like status asthmaticus, because it is a bronchodilator there. However, there are some drawbacks to it, right? So for instance, if a patient's already hypertensive, maybe this is not the greatest drug to give to them, right? Or they're having severe tachycardia, this may not be a great option for them, because that's going to be exacerbated by doing that. One way that I've seen ketamine used more frequently for rapid sequence intubation is when we have what we call an awake intubation, right? Where basically we don't want the patient completely out of it. We want them to be lightly sedated, but maybe not paralyzed, in order to achieve an airway. So I'll give you an example. You're like, why would you ever do that? Well, we had a case here where I had a patient who came in with angioedema from an ACE inhibitor. Basically, he knew he had a bad reaction to ACE inhibitor previously, but he had gone back on it. He was worried about his blood pressure, his heart, or whatever it was. He decided to go back on it. And so this guy comes in, and I mean, like, his entire face is swollen. His tongue is sticking out of his mouth. And you're like, well, there's no way this patient's going to be able to be orally intubated, because of the fact that his whole airway is just so swollen that it's going to be very difficult in order to get any kind of direct visualization. They're like, okay, well, how are we going to intubate this guy? Because he's a big risk for losing the airway. So yeah, could you do a cricothyrotomy, just open up his throat right there? Sure, but that's always going to be something you want to use as a last resort. So they're like, well, what's another way we could do this? So what they ended up doing was a nasotracheal intubation. So what they end up doing is taking a fiber optic scope, actually going down through his nose and using that in order to actually get an airway established for that patient there. You don't want to do that with someone who is completely awake, because again, they're going to start gagging, they might fight you. And so what we ended up using was ketamine to actually kind of sedate this patient enough. He was kind of out of it. I mean, he was honestly having a come to Jesus moment where he's actually talking to God at the time while we're trying to intubate this guy. But the main goal there is that we didn't want to hit his respiratory drive, because if he did go apneic, and they couldn't get an airway established orally, or they couldn't get it in time nasally, then they'd have to open up his throat and do a cricothyrotomy. And that's always the last line. So again, just an example, one way we would actually end up using ketamine for a very specific sort of patient situation. But status asthmaticus, this is a great drug. If they have hypotension, this is a good drug to use too. Because again, the main thing we worry about especially in adult patients, is going to be those dysphoric reactions, which is why you don't see it used a lot for adults for like a procedural sedation, which is like a short-term sort of thing. But these patients, if they're getting intubated, they're going to be on long-term sedation anyway afterwards. So you're going to put them on a, Versed drip or a fentanyl drip. That dysphoric reaction is very unlikely to occur because the patient's unconscious essentially, right? However, there's going to be some negative effects to ketamine, though we don't like those. So one thing, it's a sialagogue, which means it is going to increase saliva production. And so this is something that may make it more difficult for the provider to get an airway established. If there's a lot of saliva and spit everywhere, they may not be able to get good visualization of the airway, right? That's one downside. This can be inhibited by atropine, which makes sense because we know if something is anticholinergic, antimuscarinic, is going to help dry things out, like we've talked about with the urology section, we've talked about elsewhere. So atropine can be helpful from this standpoint. So if you know someone maybe because we have some kids who have like chronic drooling issues, we know there may be a problem. We might give atropine as a pretreatment if they're going to get something like ketamine, because we know that's going to exacerbate that. That's one thing. The other big deal is vomiting, which hopefully won't be an issue if you can get airway established, because once you are able to establish that airway and you fill that, I'm trying to think of can't think of the word, but there's like a little balloon you can fill up with air that actually helps to establish and maintain that airway. You're less likely to see vomiting being an issue, but say you have trouble getting the intubation done, they vomit, that has risk for aspiration, which is not great. So little things to consider there. But another theoretical concern people might be cautious about using ketamine for is it is thought to possibly increase intracranial pressure. There's no clinical evidence to really back this up, but it's a big enough theoretical concern that if you were worried about patients who had like TBI or something like that, you may avoid using ketamine for that particular purpose. So, okay. Up next, we have Propofol, or milk of amnesia, as we've talked about previously. Does anyone recall the unique sort of side effect you see with Propofol? You can put it in the chat there. So again, we like this drug because it is pretty rapid acting. It is short duration of action as well. You may find some patients, very good, Jasmine, you get green urine from that. So so again, you're going to find that some patients may get intubated with this in terms of the induction agent, and then you also see the continuous infusion that may be used afterwards. And so again, nice from a kinetic standpoint. In terms of the cons of using this, this may not be great if patients are already hypotensive, because we do know this is going to lower blood pressure as well. Not only that, there's a theoretical concern about dropping CNS perfusion, which may not be great for some patients, but it's one thing to consider. Now, if you look at this, notice that it's a white, milky sort of substance here. That's because it has to go into a lipid emulsion in order to keep the drug soluble. So that's why they call it milk of amnesia, because it has that milky kind of look to it. It also means it has a lot of egg and soy proteins that are in it as part of that lipid emulsion. And so if they have an allergy, they could cross-react with that, and that could be a problem. So that would be one thing you'd want to avoid for patients who might be receiving Propofol. Actually, I just had a case of this the other day where a physician called up. They had a patient who had overdosed on multiple medications there, but some of which included some antihypertensives. And so they ended up intubating the patient for her depressed mental status. And then she was hypotensive. And I said, okay, well, what is she on for sedation? And he said, oh, she's on Propofol. And I was like, well, okay. And then, the patient was also like on two pressors, so like norepi and I think dopamine at the time. And I was like, well, why is she on the Propofol? They're like, well, for sedation. I said, yeah, but she's hypotensive. Like, switch over to something else. And they're like, oh, yeah. So they ended up switching over to fentanyl Versed, and guess what? Blood pressure was like totally fine afterwards. So it's one of those things where you got to be cautious and realize of the unintended effects of using some of these sedative drugs and what that might mean for your patients there. So hypotension is a big one. Remember, for something like ketamine, hypertension, something you might see, right? All right, so those are the main induction agents you might see being used for patients getting intubated. So you got your Etomidate, you got your ketamine, you got your benzos, you got Propofol. Those are the most common ones. Now I want to talk about the paralytics, kind of that last stage to get your patient ready to go for that laryngoscopy, right? Because again, you want to be able to sort of paralyze all of these muscles in the throat in order to make things more compliant, such that you can go ahead and get your airway established there, right? So another term for paralytics includes basically neuromuscular blockers, or if you see NMBs, that's what we're referring to. These are really kind of interesting drugs in terms of how they work, because they are basically going to be working specifically and entirely just on skeletal muscle. They're working on these nicotinic receptors we're going to see. They only affect skeletal muscle. They don't affect any smooth muscle whatsoever. So you don't expect to see any effects on the heart, no effects on the digestive system, on the pupils, nothing, right? Just works on skeletal muscle. It also has no effect whatsoever on level of consciousness or level of pain perception, right? So if you ever hear about these like horror stories of people undergoing surgery and they're completely aware of it the whole time, but they can't move, they can't say anything, that's because they probably had a paralytic on board that prevented them from having any sort of skeletal muscle involvement. So you can't speak, you can't move, you can't do anything, but you may be completely conscious, which is why we always give our sedative agents before we do this, right? And we always want to make sure patients are well sedated prior to giving a neuromuscular blocker, okay? So that's one of the big key takeaways from these you want to note there. Also note that it doesn't have any effect on seizure activity. So for instance, if I had someone who's in status epilepticus and they're having, tonic-clonic seizures right in front of us, and say you want to intubate that patient, and all of a sudden all their convulsions go away, you're like, all right, the patient stops seizing. And then you get an EEG on the patient, you notice, oh no, those brain waves are still going crazy. It's because the paralytic can actually keep the patient from having those kind of outward manifestations, because all that skeletal muscle basically being inhibited, basically preventing all those nerve impulses from making it to the muscles themselves. So getting into the actual mechanism, I don't know why I put any sort of animations on these, but sometimes things get carried from year to year. But you're going to find there's two main delineations between your neuromuscular blockers. There's going to be the depolarizing neuromuscular blockers, and there's going to be the non-depolarizing neuromuscular blockers, right? So the only one that fits into the depolarizing category is going to be your succinylcholine, Anectine, Quellicin, a couple different brand names there. And then for the non-depolarizing neuromuscular blockers, you have a couple here. There's pancuronium, rocuronium, and vecuronium. These are probably the more common ones you're going to see. There might be another one I'll mention a little bit later called cisatracurium. And so basically they're classified based off of how they affect the neuromuscular end plate, right? So that junction between the skeletal muscle and the nerve that's innervating it, what is it doing specifically there at the receptor sites in order to cause its paralysis? That's going to be delineated based off how it's interacting there, right? So if you imagine having a neuron here that's firing a signal down through the axon, down over to the end here, and imagine there's a bunch of skeletal muscle that is being innervated by this particular nerve. This is where the drugs are going to be working at specifically. So you can send these signals all day long, but you're going to find that our paralytics are going to be interfering with that transmission from the end of the neurons over into the muscle itself. We're going to look at how that occurs here in just a moment. So acetylcholine, we know itself, affects two main types of receptors. There's nicotinic receptors and there's muscarinic receptors. We've talked about muscarinic receptors pretty much ad nauseum at this point, which is funny because if you stimulate muscarinic receptors, it actually causes vomiting, so there's that. But we do know that acetylcholine itself gets broken down by acetylcholinesterase, which we know there's different ways we can affect that. We're actually going to talk about acetylcholinesterase more specifically later on in the tox section a little bit later on, so that's something that'll come up there. And actually acetylcholinesterase is one of the fastest enzymes in your entire body, which is pretty wild. So it's very fast acting to break down acetylcholine, right? Part of that choline can then be uptaken back into the nerve, where it can then be recycled and turned back into acetylcholine later on. Now let's look at what happens here in terms of like the effects of succinylcholine. So basically, here's the neuromuscular junction. Here's where the neuron itself is going to be interacting with the skeletal muscle itself, right? So you have the neuromuscular junction. Basically what you're going to find here is that you have these receptors, these nicotinic receptors are going to be responding to the acetylcholine that are being sent out from the neuron itself. And what we're going to see is first talking about succinylcholine, how it works, and then we'll be talking about the kind of easier mechanisms to understand of the non-depolarizing neuromuscular blockers here in just a moment. But the reason why we call these depolarizing neuromuscular blockers with succinylcholine is about these fasciculations it's going to cause, and we'll talk about why that is in just a moment. But succinylcholine, a lot of people still use it mainly because it has a really rapid onset and has a really short duration of action, so some people like it for that. So basically, succinylcholine itself is kind of cool because it's basically two acetylcholine molecules attached together. Just kind of slap the two together, and it works very similar to what acetylcholine does naturally, which means it also gets broken down by plasma esterases, just like acetylcholine does. So this is something that will be important when we talk about how we reverse the effects of the neuromuscular blocker here in just a little bit later on. And of course, it's excreted in the kidneys, but very short duration of action you're going to see with succinylcholine because it is broken down so quickly. So the way that this works as a depolarizing neuromuscular blocker is there's kind of two phases to it kicking in. The first one is it actually directly stimulates those nicotinic receptors at the neuromuscular junction. So initially, you're going to cause that it causes a depolarization of the muscle. Okay, because it activates it just like acetylcholine does. So it causes a depolarization, which is why you may actually find that you get this disorganized muscle contractions or fasciculations. And you're like, well, why do we want to cause that? I'm trying to paralyze the patient instead of causing actual contractions to occur. But this is the first phase. This is how it starts out. And so if you give this, you might see patients starting to kind of wiggle around a little bit prior to the paralysis, and that's related to these effects of the actual initial activation of the receptor. What happens, though, is that over time, you're going to be overstimulating that receptor. The succinylcholine just kind of stays there on the receptor, and it basically prevents it from ever getting out of its refractory phase, right? Because we know in terms of muscular activation, the kickoff of the action potential is through sodium channel influx, just like with any action potential. And so overall, you're going to find that the cell is unable to get out of its refractory period. And if it can't do that, if it can't get back down to its resting membrane potential, well, guess what? That muscle is just going to stay flaccid. It's not going to be able to really get back to its resting state in order to have another contraction. So it initially stimulates it, and then it keeps it stimulated to the point where it actually wears out. So you get initial fasciculation, and then it causes a flaccid paralysis that occurs there. So again, this is basically just kind of talking about specifically what that is, the effects that we're seeing there. Again, overstimulation eventually is going to cause the muscles to wear out and eventually not be able to contract any further. So initial stimulation followed by paralysis. Okay, and then as that succinylcholine is being degraded, then you're going to get initial normal function happening again. So again, when I give a dose of this, or a nurse gives a dose of this to the patient, you'll see that initially they have the fasciculations. They're then paralyzed. They'll be very loose in terms of getting that laryngoscopy done. You intubate the patient, and then within 15, 20 minutes or so, it should completely wear off. And potentially, if you don't have the patient sedated, they can start moving around again, no problem, right? So again, works about 30 to 60 seconds or so. So usually we give about a minute or two for the sedative to kick in, and then you're going to go ahead and give your succinylcholine, and you're going to give your paralytic at that point there. And again, within 30 to 90 seconds or so, patients should be completely paralyzed. You may see them move around a little bit, but they're going to be completely paralyzed after that. And relatively short duration of action, about 5-10 minutes or so for the kind of the main clinical effects there. And again, overall, you're going to find that by having that kind of sustained blockade there, basically those receptors, by having it continue to activate those receptors there, as long as you're giving the drug, you can find the sustained paralysis of the muscle itself. But as soon as that succinylcholine gets broken down by those plasma esterases, the muscle will eventually go back to its resting state and can then start to work again. So this is kind of the more complex of the neuromuscular blockers in terms of how it works, because it's kind of paradoxical in the fact that it initially activates the muscle, then causing paralysis. When you get into the non-depolarizing, it gets much easier, and that'll be important in just a few moments. So because of the fact that we're causing activation of these muscles initially, that does lead to some of the contraindications that we're really worried about with succinylcholine. So succinylcholine, for the most part, for many patients, is an extremely safe drug. For a select subset of patients, it is an extremely dangerous drug, right? And so you're going to see that these side effects are particularly unique to succinylcholine and are not going to be shared with your other neuromuscular blockers, okay? And so we'll talk about kind of the debate between using one versus the other here in just a moment. So some of the things you really want to be cautious with are going to be certain types of patients. So for instance, if they have a history of severe burns within the past 48 to 72 hours, they have crush injuries within the past 48 to 72 hours, or they have a spinal cord injury within the past, say, 3 or more days or so. The reason for this is you're going to find that they're going to have an upregulation of acetylcholine receptors. Okay, that means the drug is going to be that much more effective, or going to be causing pretty significant effects on those particular muscles because they're going to be upregulated. They're going to be more affected by the succinylcholine. We'll talk about the clinical implications of that in just a moment. Other things to worry about is that if a patient has a history, even a family history of malignant hyperthermia, this is something you want to be watchful for, because succinylcholine, along with a lot of your inhaled anesthetics, are going to be likely to cause malignant hyperthermia. These are the most likely drugs to do it. The risk is relatively low, and patients have to have that genetic mutation in that ryanodine receptor for it to occur, but this is another drug that can do that. If they have a acetylcholinesterase deficiency, meaning they have less cholinesterase to break down acetylcholine, that means the drug is going to stick around for longer, meaning you're going to have a longer duration of paralysis, which may not be great for your patient. And then neuromuscular disease as well. So if they have things like ALS, if they have a history of like Duchenne's muscular dystrophy, these are also patients that are going to have upregulated acetylcholine receptors that may be affected by the succinylcholine more acutely than someone who didn't have that. And then finally, hyperkalemia, right? So what you're going to find is when you activate those nicotinic receptors on the skeletal muscle, initially you're going to have that opening of the sodium channels. That's going to flood in. That triggers the action potential that causes the fasciculations initially. But remember, part of the repolarization phase of the action potential is opening up of potassium channels to allow potassium to flow out of the cell in order to hopefully get back down to a resting membrane potential. Recall, though, because we're keeping those receptors activated, the cell stays in that refractory period and can't get back down to the resting state. But all those potassium channels are still opening. So what you're going to see is when you give succinylcholine, you're going to see an expected rise in potassium levels. Okay, we know everyone's going to get it. For most patients, it's not a problem, right? So if you imagine a normal potassium level is 3.5 to 5, and my patient's potassium level is 4, and it goes to 4.5, no big deal. If the potassium 7 and I get it goes to 7.5, that's a big deal, right? Increased risk for arrhythmia. But anyone who either has existing hyperkalemia or if they have something that causes an increase in the number of those acetylcholine receptors, like patients with neuromuscular disease, like those with spinal cord injuries that are more than 3 days old, those are patients who are going to be more acutely likely to see big jumps in their potassium, which can be potentially deadly, right? So, as I mentioned, side effects, hyperkalemia, fasciculations. You also can see, due to its acetylcholine-like action, that you're more likely to see bradycardia with this than you are any of the other neuromuscular blockers. So this is a reason why, for a lot of kids who are going to get succinylcholine, I should say, we'll give them atropine beforehand, because they're more likely to vagal down as a result of not only the laryngoscopy, but also because of the succinylcholine. So we will sometimes pre-treat with atropine because of that. Other things we'd worry about include things like prolonged neuromuscular blockade. That's more likely in patients who have that genetic deficiency in acetylcholinesterase that would prolong the duration of action of the drug, and that history of malignant hyperthermia. That's going to be increased risk there. So as I mentioned, the fasciculations themselves are not great because you can see acute jumps in their ICP or the intraocular pressure, which is why things like uncontrolled glaucoma was a contraindication just a few slides ago that we saw there. Really, the intracranial pressure thing is only clinically important. So this is something where giving lidocaine beforehand may help to prevent this, right? Because we saw lidocaine helps to blunt rises in ICP. The main effects why this occurs may be related to that fasciculations that happen there. But again, we don't really know more details than that for the most part. But as you mentioned, in some patients, you're going to either give pretreatment with lidocaine if you know that they're at risk for having increased intracranial pressure, or sometimes we'll actually give a small dose of a non-depolarizing neuromuscular blocker, something like rocuronium beforehand, to prevent fasciculations from occurring. I will tell you clinically this is not routinely done, but it's something if you ever hear about a defasciculating dose, that's what we're referring to. So this will make more sense when we get into the non-depolarizing neuromuscular blockers here in just a few moments. So as I mentioned, the hyperkalemia is expected. You expect to see about a 0.5 to 1 milliequivalent per liter increase in potassium. This is a transient thing, though, because as eventually that succinylcholine goes away and those cells can then repolarize, that will allow the potassium to eventually flow back in as a result of the sodium-potassium pump, right? However, this may be exacerbated. So imagine someone had rhabdomyolysis, right? You're going to be lysing a lot of those muscle cells. That's a lot of potassium coming out anyway, right? Or if they had like a burn injury or a crush injury that was a few days old, they're also going to have receptor upregulation that may put them at bigger risk for having this hyperkalemia. Typically for those injuries we talked about, like burns or spinal cord injuries or crush injuries, 4 to 5 days later are going to be the most critical period where you're going to see that. And then any kind of ongoing neuromuscular disease like ALS or something like that is also going to put them at a lifetime increase in risk. So these are patients who may want to avoid using succinylcholine in those them because of this rise in potassium, right? Now, if someone came in and they just had a burn, right? So say, for instance, I'll never forget the worst burn patient I ever saw was someone who had, they were cooking over a gas stove, had a cigarette in their hand, and they had COPD, and they were on oxygen at the time. And so as you might imagine, oxygen plus flames plus gas equals the guy basically turned himself into a human barbecue. Worst burn I ever saw, but coming in, he would not be at risk for having this hyperkalemia right away. It's after a few days is when you see this change, right? So he initially could have gotten succinylcholine, but if he needed to be intubated 2 or 3 days later, that would not be the case, right? So, as I mentioned, burns especially 5 days after, or any of these denervation sort of injuries, spinal cord injuries, crush injuries, those are when you are going to be more worried about that sort of thing there. And also, the renal failure issue is something to be concerned about, because patients with renal failure typically are going to have increased potassium levels anyway, as we've talked about in our nephrology section previously. So, again, if you're concerned about the hyperkalemia, just don't use succinylcholine. Switch over and use something like a non-depolarizing neuromuscular blocker instead. So the malignant hyperthermia risk is certainly something that is very rare. It's only going to be in those patients that have that particular mutation in the ryanodine receptor, which is why we ask about family history of bad reactions to anesthesia, because this could be something you can see there. And again, what you're expecting to see is that big increase in temperature. They're going to develop a nasty metabolic acidosis, rhabdomyolysis. They can develop a sort of disseminated intravascular coagulopathy, or DIC, that can occur there. And as you recall, how we treat that, whether it be due to an inhaled anesthetic or whether it's due to succinylcholine, the treatment is the same. You cool them down, you give them bicarb to help with the acidosis, and you give them dantrolene as a peripheral muscle relaxant, right? Those are the big things we're going to be doing to treat those patients there. And that's why, because it is something that can be rapidly fatal, you have to have things available to you. So the two places you'll always find malignant hyperthermia carts that have cooled fluids and bicarb and dantrolene are going to be in the ER, where patients are most likely to receive succinylcholine, and then over in the OR, where they're most likely to be using inhaled anesthetics. Those are the two places you're going to find those carts available to you. Other things you might expect to see, including things like some autonomic instability. Some of this is related to intracellular calcium issues. Or some other things you're going to expect to see as a result of malignant hyperthermia. You can see hypotension, you can see hyperkalemia, all that myoglobin coming out during malignant hyperthermia leads to things like renal failure that can happen there. And obviously, temperature is a big thing. And in fact, temperature might not be the first thing you notice in those patients. The first thing you might notice is actually an increase in their CO2 levels, like an entitled CO2, mainly because of the fact that their muscles are kind of working in overdrive, producing a lot of CO2, and that might be the first thing you detect. So it's not the temperature necessarily, but maybe that rigidity and that increase in entitled CO2. So how you can reverse the effects of succinylcholine, there's really no good reversal agent for it. Really, it's just the tincture of time. So giving the patient time to metabolize the product on its own, which is fortunately pretty short for most patients there. However, if they do become bradycardic, we can use things like atropine to help mitigate that. So using a dose prior to intubation, or frequently for giving multiple doses of succinylcholine, we'll go ahead and give them atropine to help prevent that. So other things to consider, if they're already bradycardic, give atropine beforehand. If you're worried about ICP, go ahead and give lidocaine beforehand. But be cautious. You want to be really selective in who you're going to give this to, because it can be fatal, right? And again, remember, any of these paralytics are going to have no effect on consciousness, so you always got to make sure you sedate them beforehand. So you're going to say, wow, this drug sounds terrible. Why in the heck are we even still using it? That's because for a long time, it's all we had, and it's kind of an old school thing. So typically what you're going to find is that a lot of old school providers, they still really like succinylcholine, mainly because it is the shortest acting drug that we have in terms of paralysis, and meaning you can get your patient back to where you can do a good neuro exam on them again. So that's the argument I've seen from a lot of providers. You'll find a lot of newer providers try to avoid this like the plague. And I've actually had some new providers that just come right out of fellowship, and they've never even used succinylcholine before in their entire career. So goes to show you. So up next, we have our non-depolarizing neuromuscular blockers. These are going to include vecuronium and then rocuronium. Again, these are non-depolarizing, so their mechanism is much more clear and straightforward than you'd see with something like succinylcholine, where it causes activation and then eventual desensitization of the receptors. These are much easier. These are just simple antagonists. These just sit right there on the nicotinic receptor and prevent acetylcholine from interacting with it. So these directly cause a blockade of that receptor, leading to a flaccid paralysis. They never activate it, so so you never see those fasciculations, okay? Which means you're never going to see the rise in potassium. It means you're never going to see issues with ICP or intraocular pressure. So you're going to find that non-depolarizing neuromuscular blockers avoid a lot of the issues that we have with succinylcholine. So most of you, if you ever have to use this, will probably end up using a non-depolarizing neuromuscular blocker. But if you're stuck in a bind, or if like the RSI kits you have available at your facility, you may only have succinylcholine available. So you gotta be careful with who you're going to use it in. So these are considered very safe drugs, really without a whole lot of contraindications here. You're going to see this being used in all types of patients, whether it's cardiovascular emergency, pulmonary issue, neurologic, really doesn't matter. These are good for really anyone potentially. Here you're going to find that these are going to have a little bit longer duration of action than your succinylcholine, which may be okay if it's a long intubation process. But again, if you want to have the ability to do a good neuro exam on your patient, then these are going to be less favorable because they're sticking around for longer, essentially, right? Again, don't memorize the dosing here. It's just for reference's sake. Note the onset's going to be about 2 to 3 minutes or so. So make sure give a minute or two for your sedative to kick in. Then you're going to get the paralytic and make sure you give that time to really kick in, but prior to the provider going and trying to get that airway done. So these are going to be metabolized by the liver and the kidneys, and you will find that like in the ER setting, you may only give like a single time dose to get the patient intubated. But then from a ICU perspective, we will sometimes put patients on long-term paralytics in order to help facilitate synchrony with the ventilator, or if we need them to just not be moving around due to like a surgery or due to whatever reason. Sometimes you may find patients on long-term paralytics, and these are the type of paralytics they're going to be on, the non-depolarizing neuromuscular blockers. So because they might be on drip of these are also important to consider the kinetics of them, because you could have buildup of it. You may cut off a paralytic for a patient and then they're still paralyzed for maybe a couple of days or something because it's just sticking around for so long because they've had accumulation. So for instance, with patients with liver failure, they're going to hold on to vecuronium for about twice the normal time as you would see with someone who had a normal functioning liver. So this may not be a good option for those patients there, right? Other benefits, though, is that these are going to be cardiovascularly neutral. You're not going to find any effects on heart rate or blood pressure when you're administering these, like you might see with something like, say, for instance, succinylcholine, right? Rocuronium is probably the most common one that I see being used. We like this one because it doesn't have to be mixed at the bedside. It already comes in liquid forms. That's why we like it in the ER setting. Now, some of the paralytics we're going to see, and I'll talk about a few of those in a moment, they have vagolytic properties, meaning that they can help to decrease the overall activation of the parasympathetic nervous system. So for some of these, you're going to find they actually cause increases in heart rate. That's not the case with rocuronium and vecuronium, so those are nice from a cardiovascular standpoint. We'll talk about a few that may have some of those vagolytic properties in just a few moments. Again, working through competitive blockade of the acetylcholine receptor. Here you're going to also find that the degradation of these is going to be through the liver, and then they undergo kidney and bile excretion here. So you may find some accumulation in patients with organ dysfunction. So you want to be careful with that. And then with your non-depolarizing neuromuscular blockers, we actually do have a reversal agent there. And so this is something you might see pretty frequently used in the OR setting. So for instance, if you are undergoing, say you're in surgery, you may find your anesthesia colleagues are going to be using paralytics in order to help kind of loosen everything up so that way the surgeon can go and do their thing. Well, when patients are recovering, we don't want them to stay paralyzed. We may actually give a reversal agent here. So this is where we can actually give something like neostigmine to help enhance recovery, help speed up the recovery process. And so it makes pretty good sense in terms of how this works, because if the non-depolarizing neuromuscular blockers are just sitting there on the acetylcholine receptor blocking it and preventing any sort of activation, basically it's a competitive blockade. So if I have enough acetylcholine around, I can just kick that right off the receptor, right? It's basically a numbers game at that point. So what I can do is give an acetylcholinesterase inhibitor, right? So I'm giving a drug that blocks the activity of acetylcholinesterase such that acetylcholine levels should go up. As acetylcholine levels go up, it'll then kick all that rocuronium or vecuronium off of the receptor, and then you should have normal neuromuscular function again. Okay, so this is why we're going to be giving this to help speed up recovery after surgery, or maybe we're going to see this being used in cases of, say for instance, an ICU or something like that, if you want to help to enhance recovery. Keep in mind that neostigmine will not work on succinylcholine, and in fact, it actually would make things worse because succinylcholine already activates nicotinic receptors, and giving an acetylcholinesterase inhibitor would also increase acetylcholine levels. It would also activate this receptor. So Neostigmine not going to be great for succinylcholine, but does work for all the non-depolarizing neuromuscular blockers. Again, with rocuronium, fast onset, probably the fastest out of the neuromuscular blockers, which is why we like it in the ER from an intubation standpoint. The duration may be a little more variable, so patients may be paralyzed for quite a period of time after receiving this. Keep in mind, though, that if we do need to give repeat doses, if you start to see patients moving around, maybe you didn't get the intubation done on the first attempt, you can give repeat doses in order to keep the patient compliant, in order to make sure that they can pliable to actually get the scoping done. Remember that these neuromuscular blockers don't stop seizure activity. They just prevent the skeletal muscle from showing it, right? So they just prevent those outward sort of things there. So if you have a patient who you think might be still seizing and they're under the effects of a paralytic, you have to get something like a bedside EEG done. That's the only way we're really going to be able to detect that sort of thing there. So that's one thing you want to consider. So other neuromuscular blockers you might find being used, these would be more relegated to like the ICU sort of setting there, include things like pancuronium and then cisatracurium. Probably cisatracurium is one of the more common ones I see used in the ICU for long-term like IV continuous infusions to help increase synchrony with the ventilator, just keep patients paralyzed for longer. Pancuronium is not great if you have patients with a cardiovascular history, mainly because it's vagolytic and can cause tachycardia. So that may not be great if patients have had like a recent MI for example. So that's one thing to consider there. With cisatracurium, this one we like a lot in the ICU because even if you have patients with significant organ impairment, it has no effect on it whatsoever. So you don't really see a lot of accumulation from that standpoint. It's more expensive though, which is unfortunate, but it's a very good drug for kind of longer term paralysis. So again, why do we use long-term paralysis in patients? For RSI, we just want quick one and done kind of doses here. But for long-term paralysis, you might see this used in the ICUs because one, it can help with keeping patients from moving around so much. It may help with like patients who have increases in intracranial pressure. It may help with patients who are hypothermic, maybe on purpose. If we were doing like a therapeutic hypothermia and they're shivering, we can get paralytics to prevent that and help keep their temperature low. Or if we need to keep them from moving during, like, say, a diagnostic procedure, you have a long MRI or something that needs to be done, the patient keeps moving, this may be something you consider doing there. It's not great to keep patients paralyzed for long periods of time because they can't move anything, right? So that means that they're going to be at risk for things like decubitus ulcers. You can see things like VTE because they're just not moving their legs, which means you either have to anticoagulate them with drugs or you have to use something like sequential compression devices to keep that blood moving. They're also more likely to get ventilator-associated pneumonias. You're more likely to see things like corneal abrasions, right? Because, again, they're not blinking. So you either have to keep their eyes taped shut or you have to apply things like eye ointment to prevent that from occurring. And then you can see long-term neuropathies that can develop. So it's always ideal to not have patients paralyzed, but if you have to, these are things you want to consider and things you want to watch for. So how do you actually detect how paralyzed a patient is? There's different ways to do it, but one of the interesting things you'll see, especially in the ICUs, is this peripheral nerve stimulator called a train of 4 monitor. Here's an example one looks at, and basically you place it on the ulnar nerve at 2 points, and you detect, and it'll send an electrical signal to stimulate that nerve, and depending on how many twitches you get, so for instance, you'd see, I don't know if you can see that, but how many twitches of the patient's hand you'd see indicates how much paralysis is happening, or what percentage of those receptors that are being occupied are. And so I'm not paralyzed right now. You may wish that my vocal cords are paralyzed currently, but you'd expect to see 4 twitches, right? So you'd send a train of 4, you'd expect to see 4 twitches. As you start to occupy more and more of those receptors, and again, it doesn't have to be 100%, right? You can go ahead and get maybe down to 3 twitches or 2 twitches. If you have 0 twitches, that means that all those receptors are being occupied. You have complete and total paralysis. We don't like that necessarily. It's usually not necessary. So we'll normally go between 1 and 2 twitches for most patients. And so nurses can go in, they can monitor for that. If they're getting 0 twitches, then you go ahead and dial the dose down. If they're getting 4 twitches, then you go ahead and dial the dose up, depending on what your therapeutic end goal is for that particular patient. So, getting back to the intubation, what happens if it doesn't go as planned? Keep in mind your drugs don't last forever. So, you may want to consider things like redosing medication. So, if you're using succinylcholine and etomidate, you may only have between 5 and 10 minutes of those drugs are going to be effective. So, if you start to notice the patient starting to move around, maybe starting to groan a little bit, you need to resedate and reparalyze those patients and give another dose. So, that's always one thing I think about. If I'm in the ER setting, if I'm in the resus bay, and I'm kind of present for an intubation, I'll give them the first dose, and if I start to notice things are not going well, I'll go ahead and get those second doses drawn up, so that way when the provider asks for it and the nurse is asking for it, I have it available right away and get the drugs on board and start another attempt at intubating essentially. So it's usually around the 5 or 10 minute mark or so, depending on the agents that they're using there. So again, there's a lot of drugs that are out there, and so basically, a lot of the questions I may ask have to do with like which patients are good candidates for a particular drug or not. So if I had someone who's in status asthmaticus, maybe something like ketamine is a good option, versus someone who has a head injury, maybe ketamine is not a great option for them, for instance. So there's a lot of different preferences there. Patient history is important, how they're presenting is important, but also just physician preference, right? A lot of old school providers, they like succinylcholine and etomidate. A lot of the newer people, they've never even used succinylcholine. They just like rocuronium, because with rocuronium or VEC, you don't have to think about it. You just give it, right? Because there's no contraindications. With succinylcholine, you got to do all the history. You have to ask about, did they have a history of malignant hyperthermia, and all these different things that make it more difficult to use safely. Whereas with rock, you just use it. So that's why a lot of people say rock rocks and suck sucks, right? But anyway, so again, both are good drugs in the right hands if you're using them appropriately. So I think I'm going to go ahead. That's about half of the ER section here, and I've been going for about 70 minutes now. I think I'm going to go ahead and cut it there for today. Do any of you have any questions? If you can, please put them in the chat. I'm going to look at the sticky board here. I think there were some questions. I said there were sticky notes available. Someone put us away over here. Did you hear about what's going on with Zantac? I've not heard what's going on with Zantac. Do you guys know what's going on with Zantac? Is there a recall, I think? Did I hear that? Cancer. Oh, that's specific. Yeah, I'm not sure what particular types of cancers. I'll have to do some searching on that and get back to you for the next time potentially. But yeah, I've not heard anything specifically. Yeah, I know there was a recall recently, but I thought it was more to do with a particular lot. But is there anywhere else that the paralytic monitoring can be done if the nerve conduction issues in the arms? I'm not sure. That's the most common one I've seen, but it's been a while since I've been up in the ICU where they're having to do that necessarily. So I'm sure if you looked up either an UpToDate or somewhere like that, you could probably find some other locations you can do it. I'm just familiar with the ulnar nerve being kind of the most common, but yeah, I'd have to look that up. I'm not sure if there's any specific other issues. But yeah, that could be a really big concern depending on the patient. Let's see, anything else I can answer for you all? You guys are kind of quiet today, but that's okay. Well, if anything else does come up, certainly let me know. If you have any questions or anything like that, certainly feel free to email me. And then the next time we meet, whenever that is, I don't have that off the top of my head, we can go ahead and cover the ACLS drugs. And that'll be really helpful for when you get into both talking about them perhaps in CMS, and then also when we do the summertime courses and all of that. So see, Ashley said, not educationally related, but I thought it was funny for those who've seen Tiger King. Carol said Joe Exotic was going to paralyze and kill her with ketamine. I've not gotten that far, so thank you for spoiling that, Ashley. That was so rude. I'm only on episode 2 right now, but is that show not wild? That is some real Florida people right there, let me tell you what. I love that map where they put up where all the I'm just kidding, actually, I don't really care. Where all of the tigers are located in the U.S., like Florida was just littered with them. It was pretty scary. I've not seen your link, Courtney. I don't know. Was it on the sticky board or is it in the chat? Oh, I see it now. Let me see here. I'm going to put this up on the screen here. You guys should be able to see that. Let's see. Zantac products should not be sold or used. FDA warns citing cancer danger. So let's see here. So this was posted April 1st, 2020. Are you sure it wasn't an April Fool's joke? Who knows? Let's see. Food and Drug Administration on Wednesday asked companies to stop selling all forms of heartburn drug Zantac. Let's see. Most manufacturers withdrew their products from the market several months ago after an outside pharmacy raised the alarm about the drug last year. Let's see. So September. Contaminant was a type of nitrosamine or NDMA, believed to be carcinogenic in humans. Yeah, interesting. Yeah, so I wonder if that's something where in the particular production process, so that's something that they could get rid of it or not. But that's interesting. So yeah, nitrosamines are kind of known carcinogens. You'll find that in a lot of different types of products there. But yeah, I'm not sure. Interesting. Yeah, so maybe no more Zantac. So no cimetidine and then no Zantac. So we're kind of stuck with nizatidine and famotidine potentially, right? So we've been using mostly Pepcid for the most part, but I know a lot of the ranitidine, use has definitely gone down. But I guess it's more related to this. So very interesting. Thank you for bringing that to my attention, there, Courtney. So someone asked, any idea what will happen when classes over summer? Will we be online still? Actually, I don't know. I just have gotten the same emails from Dr. Butler that you guys got in terms of the ideas. So I don't know. I think she's supposed to be meeting with the deans today to kind of get an idea for what's going to happen. So we're kind of all figuring out things together at the same time. I can tell you that in terms of like my courses, research methods and publications was all online already, so that should not be impacted there. However, there's other courses and labs and things like that. So we'll figure it out together. It's concerning, but we'll make it happen. So everyone's kind of doing the same thing. Every PA school is going through this, so we're definitely not alone in this, but we'll certainly figure it out together. But see, any other questions or anything I can answer for you guys? Yeah, as soon as I know something, you guys will know something for sure. At least during our streams. Anyway, so yeah, so you guys are free to hop off the stream now if you like. I'm pretty much done. But I will see you guys next time. If you have questions, feel free to let me know. Otherwise, I will see you all later. Thanks for joining me again. Appreciate it.